Well, personally, I believe that obesity is a disease. And if you really accept and consider obesity to be a disease, then you should manage it as a disease, and then you should treat with the drugs. If you have a diabetic patient, and if your glucose is coming down, you don't stop your treatment, you continue. The same is true for blood pressure and for other diseases. So I think if you have a drug that is found to be the right drug for that specific right patient, then I think you should continue it. However, for many of the drugs we have these days, the long-term efficacy and also the long-term safety data are ranging from 2 to 4 years. So that's the available information we have for the moment. The key message is that select the right drug for the right patients. So first, of course, as international and European, and I assume also South American guidelines prescribe that it is for people with BMIs over 30 or BMI over 27 if there are other comorbidities. You need people who are willing to embrace also to be physically active, to include lifestyle intervention. Just people taking a pill to help them losing weight is definitely not the ideal option. Depending on what kind of drug you have, will be important to define the right patients. For instance, I think that if you select a patient for a lipase inhibitor, that this is mostly for people who are fat eaters. If you have to select some individual for a serotonin and noradrenaline reuptake inhibitor, then I think you should look for people who are carbohydrate cravers. And finally, if you have the individual with cardiometabolic risk, with abdominal adiposity, then you can consider to go for a cannabinoid receptor antagonist. So for each drug, there is a very specific patient profile.